Okay, well, it's 6:32, so we're going to kick off. Thank you so much for giving up your time this evening and coming to our scan.com webinar. I'll introduce Dr. Ali Shah in a second. But before I do, let me introduce myself and tell you a tiny bit about scan.com. Apparently, I'm controlling the screen. Yes, I am. So my name's Lizzie Tuckey. I'm the commercial officer of scan.com. Scan, for those of you who don't know, is a little bit like the booking.com of the medical diagnostics world. So you can book a scan anywhere in the country through our clinical portal. We have a network of scanners, about 150 across the country. We offer online booking to all of those sites, and you can also get urgent next day appointments, and your images and report will be transferred into your portal if that's how you're ordering the image. If you want to try our portal, you can use your telephone, and if you put your camera on, you can use that QR code to create an account. It's very simple, couple of clicks. And once you're in there, it's pretty easy to make a referral. There's a bit of clinical information needed, patient information. Once the referral has been made, the patient will then receive a link to complete the booking. If your patient is an insured patient, you can also click insured, and that will take you through to a slightly different pathway for the patient. So just clicking through to the next slide. So just a bit of housekeeping. We want this to be an interactive session. I've started with a poll. There'll be a couple of other polls during the session, but please write your questions in the chat, and then we will either go through them during the session or we will come back to them at the end. But please ask questions as you go. That makes the session much more enjoyable for everybody. I am recording the session, so just so everybody knows. And we will be providing CPD certificates at the end of the session. So once again, thank you very much for joining. And I'm going to hand over now to Dr. Ali Shah, who can introduce himself. And also, let me just give up remote control. So I've done that. So now, Dr. Shah, you need to click on the top and take control of the screen. Might take a few seconds, but interesting. We've got probably osteopath is our most common specialty. So maybe one surgeon, one GP, and 7 physiotherapists so far who've answered.
I think should. Is
that working? It's a little bit fiddly. I'm just going to see.
No. I think it's working fine.
Yeah. Okay, great.
Okay. Hello, everyone. My name's Ali. I'm one of the consultant musculoskeletal radiologists. I work at Nottingham as part of a group of 9 consultants. It's a tertiary center, level 1 trauma center. So we get a lot of musculoskeletal cases here, as you can imagine, referred from the region, and we see any and everything basically. So from trauma to oncology, we have 2 separate the sections within oncology. So you've got your bone and soft tissue tumors, and then the hematological cancer, so your myeloma, for example. And then we have quite a big sports medicine department here as well. So so lots of nice things come our way, and I chose to work here for that reason. And today, first of all, thank you for coming to my talk today as part of scan.com, and it's lovely to have you all here. I'll take you through a few things. So I was asked to talk about knee imaging in particular. So I'll sort of elaborate on that in a second. I think the main theme is basically knee imaging in practice. So I've divided it into certain sections, which we'll go through one by one, starting with the basic anatomy and moving onwards to other things. So what I personally aim to cover is a bit of pathology, after the anatomy, what is my role as a musculoskeletal radiologist in terms of knee imaging? And I think because we've got, I can see we've got quite a lot of physios and osteopaths, and we've got some primary referrers as well. It would be useful to know what is it that we look for when a referral comes to us, and what are the things that should alert you to sending patients across to musculoskeletal radiologists or to musculoskeletal service. Now, I know a lot of you have been doing this day in and day out anyway, but I just thought I'd just add that bit in our slide. Towards the end, I've got some cases, and then we can have a formal question answer session. But to be honest, I'm very happy. I think Lizzie, are you coordinating there, I think, today? If anyone does want to interrupt, or if there is a pressing question, just send them in the chat and I'll be happy to answer them. So let's start. So a little bit about the anatomy first. So I really like knee joints. It's something that I was interested in. So a bit about something I didn't tell you earlier. In my past life, I used to be an orthopedic and trauma surgeon myself. And I really enjoyed doing my knee operations and knowing about the knee joint in particular. The reason why I like it is because it's not as straightforward as it first, comes across at. So it's not just a standard, flexion extension type. It's a very complex hinge joint with multiple articulations. So you've got your tibio sort of femoral articulation. There's the patellofemoral articulation. And apart from your standard flexion extension, there's a lot of rotation that also happens. And this is why knee replacements, I think there is a surgeon I was told is also on this call who would know this better as well, that this is why knee joint implants are quite difficult to design, and not all of them work the same way. There's a lot of engineering and biophysics that goes into it. But in a nutshell, I think those are the things you need to remember, that it's a complex hinge joint with your extension flexion with a bit of medial lateral rotation going on, and it's supported by a network of muscles and ligaments, all of which play a very important function. So I'll take you through some of the soft tissue anatomy, which is, because speaking as a radiologist, I think it's really important for me to kind of tell you the things, the way we look at things, because this is my job to sort of look at an image and then help answer your questions when you refer patients to me. So this is a very nice view starting from the lateral side. I like to think of it as having 3 separate layers. Now, a lot of these images are not mine. I've gotten them from various resources on the online web and the textbooks. But here, what I'm trying to show is that the lateral side is to be considered as having 3 major layers. So the one that goes forward and your prepatellar bursa comes across to the back, incorporating your biceps tendon and having your common peroneal nerve quite closely related to it. And then layer 2 isn't really that important, just has most of the patellar retinaculum, but it's the layer 3 that is really, really important. Which has all the vital structures, so your posterior lateral corner structures, to be very precise, LCL, popliteus tendon, all the other ligaments. And I think one important thing here that I would really stress on is to also have this concept where you've got your lateral meniscus, and then you've got an intervening layer of joint capsule and some other fibers which separate it from the LCL, which is very different from what happens on the medial side. And as I said, the knowledge of these structures is important, because when you look for traumatic pathology in particular, it helps identify some of these individual things which are extremely helpful for soft tissue knee surgeons for reconstruction. Now, the standard MRI that we use has 3 millimeter slice thickness, so you can't always resolve them individually. But if you know where to look, you can often get the answer that you're looking for. So just again, a slightly sort of oblique posterior lateral corner view here, which is showing exactly those same structures, the relationship of the common peroneal nerve around the fibular head. So when you have trauma to that region, or fractures, or even direct impact, that's the kind of thing that can get injured and can give symptoms. So checking for foot drop is really important in these patients. Or other way around, if patients come to you with foot drop, that's the kind of, those are the pathologies you need to be thinking about. Now going on to the posterior aspect, or coming around from posterior to posterior medial aspect, I have a very similar concept to that of a posterior lateral corner, and this is where my semimembranosus comes into play, which is this structure here. And the way I think of it is, just think of it as having 5 arms, just like your 5 fingers. And one of the arms is the oblique popliteal ligament, which is one of the important structures. And then the 5 arms are essentially what it gives to the capsule and parts of the MCL, which is essentially your deep MCL. So you've got a capsular arm and an anterior arm, a direct and an inferior arm, which you'll see in a bit more detail on the next slide here. So that's your oblique popliteal going, part of the capsular arm, anterior arm, that's your direct arm, inferior arm. The labeling's a bit off. These numbers should slightly move upwards, but that's what it is. And the capsule has been divided here into 3 parts purely to give the explanation that the MCL, or the medial collateral ligament, is deeply related to the capsule here. So this is a superficial bit of the MCL, and that's the deep bit, which is essentially the deep part of the capsule. And the medial meniscus, which I was trying to mention in the earlier bit of the lateral corner, the medial meniscus just abuts the capsule. So this is why injuries to this side almost always result in medial meniscus tears. A little bit moving from the anatomy, but also some of the things that we do within imaging. So looking for abnormalities, be they acquired or congenital. There is lots to look at, and lots out there if you go into texts or online resources. But to keep it really simple, so there is the Caton-Deschamps index, which some people use. I tend to use the insult Salvati or the modified insult Salvati to look for patellar abnormalities. Again, these are fairly common either in the context of trauma, knee pain, especially in young patients, with regards to the orientation of the patella, whether it's high riding or low riding. I have a little something of mine to remember this, so I just say, if the patella is high, think of it as above, A for above, A for altar, B below, B for Baha, and then you're basically measuring the patella length along with tendon length to calculate that ratio. But the concept is really simple, that the tendon length will increase as the patella goes up. So the ratio would start to go higher, which would be your patella alta. And if the tendon length goes smaller, which is your measurement here on the top, the ratio will keep going down. And as with most things, there is a range, both for the insult Salvati and the modified insult Salvati. Again, specifically for patellofemoral joint, other things that people look for are, things like patellar inclination, trochlear groove. Some people measure the sort of posterior condyle and the tilt of the groove here. I personally tend to not go into so much detail. I think the thing that I use most to kind of look at patella tracking, or what the knee surgeons that I work with want to know, is often the trochlear groove and the tibial tuberosity distance. And the way we calculate that is we simply, on a CT scan, we would put a marker at the deepest point of the groove and scroll down all the way until we find the tibial tuberosity and measure that distance. And it should roughly be within 20 millimeters as a normal. And anything higher than that, that means you have an abnormal ratio and therefore can have problems with a maltracking, anterior knee pain, patella dislocation, all those sort of things. Now moving on to pathology. Any questions on what we've just gone through? Like I said, I just thought I'd just give you a very brief idea of how the knee joint looks like to me as a radiologist, things that I look for, and how, as we are going into pathology, that would correlate don't think I can see any, but yeah, please feel free to, oh, someone's actually said something, enlarging the slides. Is that something we can do? On my screen, it's already full screen actually, so I don't know.
You can zoom in on them if you just zoom in on your computer. Let me just see if I can make them any bigger. Stand
Because I think on my screen it's already full
bigger.
screen, so.
Yeah.
Okay. So now comes the pathology bit. I think from a referring point of view, I think this is what I think the things you look for in the clinical world. And again, like with most things, so I always like my things in boxes. It's just easier to remember. It's easier to work on them, and it's easier to then try and fit them into the answer boxes as well. So when I get questions, I put them in boxes, and then it's easier to just allocate them in answer boxes as well. And here I've just put a CF. Surgeons would know of a surgical CF. This is very similar to that. I call this my radiopathological CF. And I divide the conditions. So when I get a referral, let's say patient's got knee pain, we'd like an ultrasound scan or an MRI scan. So the thing that I really want to know is what box of pathology I can put this in. Is this degenerative disease or arthritis? Now I've separated them for a specific reason, because I know a lot of people think of osteoarthritis, and there's a big debate out there whether that's degenerative disease or not. So osteoarthritis also comes in this, and then I also put some of the other arthritis or arthropathies in there, for example, rheumatoid arthritis, or psoriatic arthritis. And then we have the more systemic conditions like ankylosing spondylitis, sarcoidosis, all sorts of the weird and wonderful diseases. I know gout is considered sort of more in the arthropathies, but I like to put it here because it's a bit more sort of systemic problem. And then infections of any sort, neoplasms, congenital issues, developmental, and then finally trauma. And working from there, just a few pictures to show you. So the degenerative has a spectrum, so from mild sort of medial compartment away, where we're just seeing some subchondral bone sclerosis, and perhaps very little joint space narrowing, to fairly bone-on-bone articulation here at the patellofemoral joint, and osteophytosis, subluxation, and much more changes here as well. For example, here, as we can see. Then systemic conditions. So these are the inflammatory pathologies. So here is an image of an ultrasound scan. So those of you who look at this in normal practice, you can appreciate. So this is where the probe is oriented longitudinally, so along the long axis of the knee. This is just above the patella. You can make out the patella here, and this is your quadriceps tendon. That's your femur down there, and there is a suprapatellar effusion with lots and lots of synovial thickening, effusion, debris, and synovial fronds. So this is synovitis. And on the MRI, which is the picture on the right, you're seeing exactly the similar picture. So you've got the suprapatellar pouch, you've got this synovial proliferation, fronding, synovial thickening. You can see how thick that is. And then edema going all the way around here within the knee joint. Just a bit about the MRI. So these are the fat suppressed sequences. You can see the fat appears dark everywhere. So the benefit of that is because we suppress fat, it makes the fluid stand out as a contrast. So it's very good to look for edema, inflammation, and that sort of pathology on the MR scan. Infection, these are two pictures of the same patient. Here you can see that there is some lucency that's developing in the cortex of the bone. There is some periosteal reaction. So those of you who look at reports, look at images. So for example, GPs in primary care, physiotherapists, I think osteopaths as well, all of you. I'm not sure how many of you have access to imaging, but all of you, if you do, those are the things that we look for as radiologists. You know, periosteal reaction is almost always something to look out for. There are entities where periosteal reaction can be as part of a more systemic problem. But if you see pain with periosteal reaction, that is always alarm bells. And here, you know, we can see this lucency. What we can also see, I won't be able to, oh, actually I can, I didn't know I could do this actually. What you can also see is this little bit of sclerotic bone here. So that's called a sequestrum, if some of you have heard that term before. So that's where essentially the bone cavity gets infected, a part of the bone gets infarcted and basically just dies off. And then there is new bone formation around it, which is called the involucrum. And at this stage, there's a cloaca or an opening, which is like a sinus tract opening that forms in the bone and constantly discharges pus. So once that sort of thing happens, then you can be assured that unless you go in and intervene, wash this whole thing out, it will probably not heal despite antibiotic treatment, because that bone in the center is dead. And there isn't really anything antibiotics will do to it. And this is again the fat suppressed sequence I was mentioning earlier. So you can see bone edema stands out really nicely. You can see all of this area is infected with osteomyelitis. That's the term that we use. You can see the cloacal opening. You can't really see the sequestrum here, but you can see the soft tissue edema, and you can just see some periosteal reaction around the site there. Sorry, I'm just quickly checking chat from time to time as well to see if there's anything there. Neoplastic. Now, neoplasms of the knee, again, can be primary or secondary. So primary tumors of the bone, usually younger patients, you see your osteosarcomas, Ewings. A lot of the bone lesions happen around the distal tibia and, proximal tibia and distal femur. So all your lesions are, so your osteochondromas, your giant cell tumors, non-ossifying fibromas, any and all will happen around the knee joint, really. So that is a very, very good joint to, you know, to catch all this pathology in. And then you've got the secondary tumors, which can be metastatic, or they can be tumors, then they form around the soft tissues. So ours being a sarcoma center, so this is one of the cases that we saw. Patient got referred with a lump on the back of the knee, thought as a Baker's cyst, but rapidly enlarging. And some of these can be quite innocuous, but you can see how impressive that is. It's grown into, I think on measurement, that would have come out to be nearly 8 to 9 centimeters craniocaudally. And this turned out to be a liposarcoma, and the patient ended up having surgery for that after the MDT. And yeah, and here the sequences, if any of you are interested, again, so we've got some fat suppressed sequences on the left, and you've got the T2 rated or the fluid sensitive but non-fat suppressed sequences on the right. So as you can appreciate, the bone looks white or bright on the non-fat suppressed sequences. If you're looking for bone edema, it might be tricky to appreciate that here. But it's really good to kind of look at the internal structures and what might be present within the, you know, tumors. Is it blood? Is it protein? Is it sort of mucinous material? So that's why we do different sequences to sort of work that out. Developmental deformities. So this is something I touched upon briefly. So you've got a patella that's quite low lying. So you're below, so your patella baja. Here's a picture of a patient with recurrent patella dislocations, either due to shallow trochlear groove or an increased TTTG. But what I'm trying to say here is you can't just work that out from one radiograph view. So this is when the patients dislocate their knee, they get seen by a surgeon who or a musculoskeletal specialist who examines them, checks their patella tracking, and then advises special views for us. So like a skyline view where you see the trochlear groove and the patella sitting, or more specialist views where we can calculate these distances to then help our clinicians work out what is the actual nature of the underlying etiology which is causing these problems. And trauma, so trauma that we see again is also on a spectrum. So you can have this, which to the eagle eye would have spotted is actually a very, very bad injury. So this patient ended up having a dissection of the popliteal artery. So as you can see, the knee is dislocated here, the tibia is posteriorly translated, femur has gone anteriorly, and perhaps just by sheer traction and the stretch of the tissues, this patient ended up dissecting the popliteal artery and ended up having a vascular repair. So for us, it's really important to report these injuries, but I also add alerts to my reports as and when I can. So for example, in this case, I would not just report this as a knee dislocation. I would say that there is a tibiofemoral dislocation, but please contact the orthopedic team for urgent neurovascular status and refer to vascular surgery as appropriate, because I think that's our job as radiologists to kind of guide clinicians just so they can anticipate what can be wrong, because in ED, when you're seeing these patients one-off, it can be very busy and it can be very difficult to then work out what other injuries could happen. So having that sort of experience on board on our side just helps clinicians go forward in the right direction. And this, I mean, it is a really, what do you say to this? So this is essentially where the, distal femur's got a comminuted fracture. The femoral condyle is basically lying in the posterior sort of knee recess. There is a big, large open wound at some point. So this is where we predict that, this tibia would have gone out. The femur would have gone out completely. It's a large open fracture, so high risk of infection. These patients sometimes end up having amputations, if this doesn't heal, particularly with a large skin defect here. Yeah, so those were some of the things that we look for on a spectrum of different types of pathologies, and a little bit about my role. So this is just for jokes. I put it up there. The people often think of radiologists sitting in our air-conditioned rooms with our feet up, reporting while the rest of the clinicians and doctors across the hospital are running across from ward to ward. Bars is actually quite a busy job here where I work. As an, I think what I say is, you need to help me help you. We can't function without our clinicians, with our referrers. So physiotherapists, sonographers, as part of our imaging policy, they send a lot of MSK stuff to us as well. More, or the primary care clinicians, all of you are really important for us to help the patient, because what you tell me, comprises a major form of the information of what I would then use with the imaging that I have in my arsenal to combine it with, and then work out a plan for the patient, and then and then advise onwards. We've got lots of imaging modalities, which I'll touch upon in a second. We've got intervention options. So there is intervention of purely, if you're talking musculoskeletal intervention, so we can do joint injections, aspirations of abscesses, cavities, hematomas. We can do biopsies, so CT guided, ultrasound guided, of soft tissue tumors, bone tumors, and then there's a whole sort of breadth of therapeutic musculoskeletal interventions, from shoulder hydrodilatations to, injections, steroid and local anesthetic injections to barbotage and what. And yeah, this is what I kind of did allude to earlier in some of my slides, that radiological correlation is actually a thing. So back when I was saying that, we see someone who's been referred to us for an angiogram of the knee, and then we have a knee radiograph that shows that the knee was dislocated at some point. So we do work out, or either at that point or when you would report that image, that look, this knee is grossly dislocated, there is a risk to the popliteal artery. We would suggest do your neurovascular status check, but also have a very low threshold for doing an angiogram should you be worried in the slightest. So we look at our images and we radiologically correlate that with the patient's condition to predict what could happen as a result of what we are seeing on our screens. This is quite funny and sad at the same time. And the reason why I say this is that, I mean, I come from a time when we were junior doctors. The rule used to be that you need to diagnose the patient with appendicitis without looking at the bloods based on your history and clinical exam. And if you can do that, you are allowed to go into theaters and operate on that case. That was the rule. You can go to theaters, but you have to use your clinical skills, which sadly we've seen, just deteriorate with time, and they're getting worse and worse and worse. And I think in part, I suppose radiologists could be blamed for it, because the imaging really helps narrow down things. I mean, I know I'm drifting off from my own specialty, but the general surgeons are a really good example of this, that nowadays no one really goes and examines the patient. They just order a CT scan, and that tells you very quickly what's wrong with the patient, which is good for patient. I'm not going to deny that. But what that means is that people's own skills are not as good as they used to be, because people are just not used to examining them, because the F1 that would be shadowing the general surgeon would never have time to showcase their skills, because they would just have a CT result right there. And I think this is really important, that whoever you are, osteopath, physiotherapist, podiatrist, any other musculoskeletal specialist, you need to have your clinical skills out there. And I'll tell you why that is. That, sometimes, yes, if someone's got knee pain, you can order an MRI scan and I'll tell you what's wrong. But it's really important if you tell me what you think might be wrong, so I can, before the imaging even starts, I can start with the correct test. And this is what I always say, the tests don't cure patients. They don't treat disease. They help you, but if you do an MRI scan for the wrong reason, you will end up in a lot of problem afterwards. Because if I do an MRI scan on a knee and all I see is fluid out there, and you've not told me that this patient's run a temperature, that will completely change my interpretation, versus a similar patient with knee pain with fluid who has a known history of rheumatoid arthritis. Both of those knees will look very similar on the MR scan. And I might actually get it wrong if you've not told me what you think is wrong with the patient, how they presented. Was the knee hot? Were they running a temperature? Were you suspecting infection, and all those kind of things? And here is a slide. I mean, I've not done any polls myself, but any of you want to give it a go in the chat to say, so if, why do you think this patient might have knee pain? And this is a real scenario. So this radiograph, when it happened, what I saw on the referral was literally that knee pain query cause. And I just want to put it out to the floor just for a few seconds to see, can anyone guess what could be wrong with this knee? Why does the patient have pain?
Well, guys, we must have a class SWOT. He's going to get the right answer. Just drop your note into the chat, or you can put your hand.
Yeah, some very good answers coming through. And I think this is kind of proving my point here, what I was actually trying to convey. So we've got answers coming from post-op. Yeah. So you're absolutely correct. How do we not know that this is not a post-op knee? I mean, I mean, you can do some guesswork, or you can use some of the imaging clues. So I'm not seeing surgical clips. So this probably isn't immediately post-op. It could be late post-op following clip removal. So that is one clue there. Failed TKR, absolutely. So this is a joint which you can clearly see has already been revised. This is not a primary knee replacement. Primary knee replacement doesn't look like that. So yes, failed total knee replacement can have lots of problems, from scar tissue, from nerve pain, to just chronically failing implant. Infection is a big shout. Again, this is a revision knee. Infection can be a cause of pain, implant loosening, dislodgement. All of those are all valid causes. And this is why I'm saying that unless there is a differential from your side, that you tell me that, look, we don't think it's post-op pain because the patient has had this implant for a while. We think this could be infection because the patient suddenly presented with a red hot swollen knee, was absolutely fine, and their inflammatory markers are high. That helps me narrow it down. Look, and then I'll just show you some of the other tricks that we use in imaging. So look at the legs. There is absolutely no muscle there, chronic muscle wasting. That could in itself be causing pain just by the sheer fatigue of having that implant in your leg. Scar tissue, that could be causing pain, along with all the other things that you've said. So the problem is that if you say knee pain, I can't tell you hand on heart what is the actual cause, because it could just be one of anything that you've said. And it's only where we work together that, you know, we can come to a conclusion. And, you know, like you say, oh, you know what, she's already had this knee replacement for a long time. She suffers from chronic muscle wasting, but we are concerned about, you know, losing. So then I would say, okay, fine, that's a good shout. What we can do is we can do a type of, like, do a CT scan to see what the bone cement and the implant bone interface is looking like, and if there's any loosening. And then I can give you an answer straight away. If you're telling me infection, we can do certain types of scans, including MRI, some of our more sort of nuclear med studies, like white cell scans, for example. They can help narrow that, or I can aspirate that joint for you, and I can send a sample to microbiology and see if infection is actually the cause here. But it all works if you and I work together. Otherwise, you know, this radiograph, anyone can be trained to interpret this. It's not going to help the patient in any way or form. And yes, and this is where, I think I'm to blame as well, but definitely, you know, we do see this in radiology, all these sort of vague reports, because we're not sure. So we'll say, okay, so these are sort of indeterminate appearances for an infection, because, you know, there's a little bit of issue in there and that. Clinical correlation is advised, and you know, all these words when we are not sure. And sometimes, yes, genuinely we're not sure. So sometimes I'm not sure, and I would pick up the phone to the clinician. But a lot of times when our reports come across as we don't know what's going on, is because we genuinely don't know, because it could just be one of many things out there. So if you want direct, concise, you know, reports answering the clinical question, the most important thing needs to be there, which is the clinical question. And then just a bit of when to kind of refer. I think someone mentioned this earlier in the chat. Yeah, so referral, I think I trust my clinicians. I think all of you, wherever you're working, you've got enough experience on board to you know, just get alert, you know, when you think, okay, this patient doesn't look right, we need to get some imaging on this patient. There are of course some aids to help you there. So there are local, regional, and national guidelines on referring, like there's the, you know, Ottawa knee and ankle rule, all those sort of things for trauma. There is the IRFA guidelines, which surprisingly enough, we don't get to see a lot in our practice, but we know they're out there because they were done by the Royal College. And if any of you want to go and have a look, you can, because I'm pretty sure they are fairly easily accessible. And they kind of break it down as to, you know, what are the things that would, that should then constitute a referral, and, you know, how you should then refer it forwards. If you're worried about the patient, absolutely. And sometimes it's this anxious patient where, you know, they've had loads and loads of tests, and you know, you've tried to examine them, bloods are normal, and then the patient comes our way, says, look, you know, we just need some sort of imaging to find out what is going on. And we do find stuff sometimes that is sometimes really unexpected. Like the other day, we saw a young chap who got referred to us with knee pain. Didn't really have an unstable knee, but he just didn't feel right. He's an active sportsman. And I think the hesitancy initially was, what should we refer this patient for? And then eventually just got a referral for an MR scan that looked, the patient's young, we don't know what's going on. Doesn't look like the knee is infected, doesn't look like the knee is unstable, isn't really swollen. Can you please do a scan? And because the patient's really anxious, and we did a scan. And interestingly enough, we found a mass within the knee, completely incidental finding. I don't know if any of you have heard of the entity called PVNS, pigmented villonodular synovitis. It's just like a soft tissue tumor. And basically all that was doing is growing inside his knee and causing block to his movement. So he felt that his knee was unstable every time he ran. But actually it was this that was causing problems. So don't worry about referring those anxious patients as well, because sometimes the patients know that there is something wrong, even though we can't figure it out by examination and you know, some of the standard blood results. So say usually we ask for X-ray. Sorry, I'm just reading a question here. We ask for X-ray and MRI physio. So why would you refer for an ultrasound? X-ray or MRI? Ah, okay, fine. Okay, pardon me if I've got this wrong, but I think the question is that we normally go for X-ray or MRI. Why would we go for an ultrasound? It's a very good question. It's because of two things. So MRI is a more time-consuming investigation. Not everyone can tolerate MRI. There are some contraindications to MR. And also, as you know, currently the waiting list in the UK, at least in the NHS, are exceptionally long, months on end. And ultrasound, surprisingly enough, at times gives as good and sometimes even better information when it comes to resolution compared to an MRI scan. So for lumps and bumps, for example, around knees, especially if they're within the sort of dermal subcutaneous tissues, you may find it better to evaluate them with an ultrasound than an MRI, because the slice thickness of an MRI, as I mentioned earlier, is 3 millimeters. So the resolution is bad compared to an ultrasound, whereas the ultrasound looks at lesions very, very clearly. So it can diagnose things better than an MRI in some cases. Not for trauma though. I mean, trauma ultrasound is very limited. I mean, you might be able to see a bit of MCL tear, or if you're lucky, you know, some of the internal ligaments, but that's it. You really need to have an MRI in that case. Someone's asked, do you operate on PVNS? Yes, so PVNS goes to our MDT. It gets discussed there. The main thing we need to establish that is this is PVNS and not an aggressive soft tissue sarcoma, which it can be and can look very similar. And from then on, it then moves on to surgery, which will be dependent on what kind of tumor it is. So, you know, straightforward tumors you could probably remove arthroscopically. But, you know, if you're looking at sarcomas, you need staging and you need to have a more radical dissection and an operation. Okay, so those are the few things. Just going to move. And yeah, no clue. So by no clue, you know, it just means that, you know, very simply, we've exhausted all our efforts. What is it that's going on? And then, you know, if you write that in the clinical information, then we'd be happy to have a look and see what we can do on our side. And these are some of the more specific things. So chronic pain, patients, so especially for people in primary care, physiotherapists, osteopath colleagues, patients who've got chronic pain, they've had a specialist review, and that kind of agrees that, this patient needs further imaging. Absolutely fine. Acute cases, locking, that needs to be done urgently, because especially young patients, you need to get that knee unlocked with an arthroscope by an orthopedic surgeon. Sudden onset swelling, again, depending on what you're thinking here, if it's not a recurrent sudden onset swelling and you're thinking infection, again, urgent imaging, sampling, that sort of thing. Instability, trauma, including late presentations, and masses, especially new ones, or any new change. So that lipoma that's been present for a long time has suddenly started to grow in size. You'd want to refer that patient onwards. And referral, so this is now breaking it down bit by bit, what to request. I think this comes with experience, and this is where your guidelines and the IRFR would really help you. And I think this also in part answers the question, why would you request an ultrasound? Because certain things have got certain investigations that you would start with. Like someone's got known osteoarthritis, they're in their late 50s, early 60s, knee pain getting worse during the night. You wouldn't necessarily say, oh, can I please have an urgent MRI for this? That's not going to happen. You would need to have a baseline x-ray, refer it to a specialist, see what's going on if they agree with osteoarthritis. If knee MRI is needed for a condition, then we can do that. But this is really important, crucial. What is it that you're looking for? What kind of investigation I should go for? This patient's got a lump I can feel under the skin. Am I going to request an x-ray? No, it's probably not going to be of any use. I'm probably going to start with an ultrasound. That's the kind of thing I'm getting towards. Then there is this thing is, some people think, oh, I shouldn't really waste time, and that's really appreciated. From our side, sometimes our colleagues think, oh, should we just do a single best test? Or let's just do that MR, at the first instance. Or should we start from the basics? I would always say start from the basics. If we think that something else is better here, I would suggest that. Just to share an experience, yesterday, one of the emergency doctors came to us and he said, look, we've got this patient. She's just recently given birth. She's just suddenly presented with, so she gave birth a few weeks ago, but now she's got this swelling in her hip. She said that for the last week, her hip was, feeling a bit odd. And now we can see a lump in front of the hip joint. So we were thinking, let's just do an ultrasound because it's quite good for lumps and bumps. And that's absolutely the right way, of thinking. And probably some of my colleagues would agree to that. But this is where I went for the single best test approach instead. So I said, look, this is a young patient, no previous history of any problems. She's given birth, but is otherwise well. She's suddenly, come in with this hip pain, and now she's got a swelling in front of her hip and she's struggling to weight bear. What am I going to be worried about here? I mean, my main concern would be infection of some sort that she might have caught during her stay in the hospital. I don't know how she gave birth. Was it just a cesarean section, whether she had some infection, whether she had to be on antibiotic. MRI, I would go for, because even if I see a swelling around the hip, I can trace it down to the joint, but then I don't know where to go from here. If I do an MRI, it ticks all the boxes. It will tell me what kind of swelling that is, where it's coming from. Is there any problem with the hip joint? Is this a muscular swelling? And, any or all of those things. And the differential here is quite wide because the doctors weren't really sure what's happened, whether it's something as benign as iliopsoas bursitis or a hip effusion, or she's had a line there, it's an aneurysm, we don't know, God knows. So this is where I went for the single best test approach. But by and large, baseline test, starting from the basics, is always a good way to go. And understanding of pathology. So this is part of the reason why I have those slides. Always try and read around your patients' presentations or the pathologies they come to you for, just so you know what kind of things you'd be expected to look at. So if you give me those 3-4 differentials, I can help narrow it down. And clinical question, it's impossible for us to, write a report properly if there is no clinical question. And just talking a bit about imaging, so all of these things we use in the musculoskeletal world, from plain radiograph to ultrasound, CT scans, MRI, and nuclear medicine. A lot of us don't report nuclear medicine scans, so the ones like white cell scans, PET CTs, but we do look at those images, and we work closely with our nuclear medicine consultants and doctors to work out what's going on here. I think here I've just got some images, so for people to just look at and just try and see if they can work out what's going on here. It's just a list of interesting cases I just had at the end, so I thought I'll just show you. No radiological talk is done without showing some nice images. Any guesses to this one? This one's a pretty straightforward one, actually. Yeah, absolutely correct. So this is your standard medial compartment array, degenerative change, also developing some lateral compartment arrays, but some osteophytosis coming. So these are the little lips forming here. So yeah, that's osteoarthritis, absolutely correct. So this is an MRI fat suppressed sequence. Any guesses to what this is? Yeah, very good. So this is a meniscal tear, as you can see here. But this is slightly more than that. So this is, interestingly, a discoid meniscus. So meniscus, just to give you some of our tricks of the trade, menisci you should see as bow tie, like that. This is not the same as this side, and I'll tell you why. This is just an interface you're seeing between the two articular surfaces, that line there. This is where the meniscus is like a disc, and this is a congenital variant. So this is where the meniscus is not C-shaped, but like a disc. So it occupies that space between the tibia and femur. And as you can imagine, it's subjected to constant shear as the knee moves as a hinge joint, but also with this medial-lateral rotation. So over time, you develop meniscal tears, but you also develop stress fractures or subchondral fractures because you're constantly grinding your bones. I don't know if any of you have actually felt a meniscus in cadavers, or I don't know if any of you eat meat, you've actually felt what a meniscus feels like. It's really firm and really hard, and it can very easily erode the bone. So here you're actually getting some of that chondral fissuring and irregularity of the cartilage. And if not treated, this will result in full thickness chondral loss and degenerative change. I think there's a question that was directed here, which I missed earlier. Said, what are the clinical signs of a failing hip replacement joint that has been in for 20 years or more? I don't think I have an image of a hip joint, but before I move on to the next image, I can certainly answer that question. So the main thing of a failing joint, so don't get me wrong, but these joints that were put in 20 years ago actually do a lot better than some of the implants that have been present since 20 years actually. So like your Charnley hip, I don't know the person who posted this question, if this is an orthopedic surgeon. If he is, then he would understand what I'm trying to say. The Charnley hip, it's an ancient implant, but trust me, we see these in patients in their 80s and 90s absolutely fine without any problems and working much better than some of the new implants that we find nowadays. I think one of the clinical signs, the first clinical sign will be pain. In a joint like a hip joint, you will feel pain once that joint is failing. Now, the other things, would be related to why that joint is failing. Is that joint failing because it's developed infection? Is that joint failed because it's developed wear? When it develops where, you can have all sorts of things. You can present with joint dislocation, instability, clicking, that sort of thing. And then, so from a clinical point of view, I think those are the main things. When you examine the patient, you would flex the hip and you'll notice that, it just clicks a bit, doesn't feel quite right. You might feel a bit of grinding. And then the imaging will then show you some of the signs. So the cup will be sort of thinning out. The orientation might be off, or I'll try and see if there is a picture of any implant. I'll tell you what I meant by the bone implant and the bone cement interface. So you start to see lucencies there. In worst case scenarios, when the femoral stem is completely loose, it will go into varus or valgus because it's just shaking so much in the femoral canal. So all of those signs will be present. The early signs are very subtle. Early signs will mainly be pain on clinical examination, and sometimes we have to do MRI scan to look for bone edema, or sometimes do nuclear medicine scans to see uptake, which helps us sort of diagnose what we call aseptic loosening or failure of the implant. I had a patient with moderate hip pain. The X-ray was reported as mild OA with an incidental large bone island. No, bone islands themselves wouldn't really be causing pain. Weight-bearing pain could be due to OA. Yeah, mild OA could be causing weight-bearing pain. Yes. Yeah. Okay, so that was the discoid meniscus. This one. I think we're nearly coming to the end of the time, so if you want, I can quickly whisk past these. Yep, effusion. So there is an effusion. So this is what we call a double PCL sign. You see two, so that's the posterior cruciate ligament. This is where the medial meniscus is torn and shoved, sort of shoved in that condyle. You've got a large effusion. You've got the edema around the condyle. So this is a traumatic injury. Yeah, you've got meniscal tears, effusions. So that's that. What would happen if an osteophyte breaks off in the knee, or is that unlikely in an OA knee? No, osteophytes can break depending on where the osteophyte is. If it's, it can break, it can form a loose body. It can form a loose body, it can cause, chondral erosions and knee pain, clicking, locking. This is the patient I showed earlier with the infection. And that's the story. That's how this had happened. This patient had young patient had a fixation of the tibial tuberosity fracture, where the tuberosity got avulsed as a result of contraction of the patellar tendon that was fixed, with this wire, and at some point had infection there and then resulted in that. So this is also what I was talking about, the radiological correlation. So if that's the MR I'm looking at, and that's the X-ray I have in my previous imaging, I know that there was surgery, so I can very easily say that this is infection and not some weird bone tumor, because some of the bone lesions might look like that. Again, here this is a complete anterior cruciate ligament rupture. So one, another one of those secrets. So we always look at the alignment here. You can see the tibia is sitting here. If you draw this line here and here, this is way forward. So this tibia is basically doing the anterior draw test that you would do in clinical practice. So I use a lot of this in my practice. And when I report imaging, I use my clinical tests in my radiological reporting. So I say there is an anterior draw of the tibia in relation to the femur with a high-grade tear of the ACL. So the clinician already knows this is an unstable injury. This is a Baker's cyst. So these are axial images and longitudinal images to confirm that this is not a vessel. You're just seeing that bit there. And yeah, this is one of the things that gets referred to us for ultrasound. Part of the reason for showing this is if you suspect these pathologies, please do refer them on to an MSK radiologist, because this is what we see. This is another Baker's cyst, but quite a large one. And this is a lesion behind the knee. You can see a tail going on. Any guesses to what this is? You can see it here as well. Same thing behind the knee, a little tail going on. It's something to suspect if people say, oh, I've got a lump at the back of my knee. And sometimes, you know, when I sit down, it sends tingling sensation down my leg. The Baker's cyst was this one. So the Baker's cyst, the way it's described is that it's, some people say it's just part of the synovium and the joint fluid that comes out between your semimembranosus and the medial head of gastroc. And that's the classic location it appears between. If it's not there, it's not going to be a Baker's cyst. So this is way too far out. So that's why we know it's not a Baker's cyst. So perfect. So that's a neuromus. It's a nerve sheath tumor. So it's in sort of kind of got this tail. So that tells us that this is along a tubular structure. So there's a nerve tumor, and the history was that. So, you know, if you have a patient with a lump that says, oh, I get these tingling sensations, think of neuromas. And ultrasound's the way to go. You wouldn't do an X-ray. You can do an MR, but ultrasound will probably pick this up anyway. This is just, again, that synovitis. So just saying any patient with knee swelling, you're suspecting synovitis, we'd be happy to look at those for you. This is the metalwork. So when I mentioned loosening, although this is not the example I wanted to give you because it's not a knee prosthesis, but you see, so that's the implant, that's the bone. You start to see lucent lines or darkening around here along the implants. That's the sign that the implant is failing. So this one is, again, why investigations need to be interpreted carefully in clinical context. Now, this is very interesting where the answer is on the X-ray, but the patient was actually told that after they had the ultrasound. So the X-ray was reported as, you know, there is a distal tibia fracture which has been fixed. No metalwork failure. Although you can see there's a little bit of back out, but they probably didn't want to report it at the time. I'm not sure why. It's only when the patient came with knee pain and the referrer, for some reason, perhaps because they thought, you know, MRI, you'd get metal artifact, and rightly so, said, oh, can you please do an ultrasound because the patient's getting pain along the iliotibial band that goes along sort of his thigh. So we started scanning him from the top, and as we were coming down, we saw this fluid that was running between sort of just under the iliotibial band. And then when we went to the point of maximal tenderness, we found this screw to be sort of there. So all that had happened is over time, somehow that screw has backed out or was never in the right place. And for whatever reason, because, you know, there's been some soft tissue wasting or, you know, atrophy, this is now impinging on and causing friction symptoms on the overlying soft tissues. And that was the cause of the knee pain. Not the implant failing, not infection, just this screw. But we were able to find that out because, you know, we just kind of worked with what we were told by the patient and by the clinician. So quite an interesting case. And that's it from me. I think I've gone just over. I think I was given until half, so we've just gone a bit over. Any other questions? Happy to take. I mean, I'll be happy to also answer them via email later on if Lizzie or Lily anyone can just forward them to me. But thank you so much for listening to me. And yeah, just fire away if there's any questions or.
Thank you so much, Dr. Shah. That's been really, really helpful. I think everyone enjoyed it and everyone stayed super engaged. But yeah, if you do have any further questions, then ping us an email and we'll answer them in hindsight. And thank you very much for feedback on future sessions. It looks like shoulders the winner, but I'm not sure whether that's because it's at the top or whether because it genuinely is the winner. The problem with polls. Anyway, we'll let you get on with your evening. Thank you again, Dr. Shah. We really appreciate it.
No, that's okay.
And it's been a really informative session, so thank you.